So welcome everybody to our March Health Services and Policy Research Rounds. For those of you who I haven't met before, my name is Catherine Donnelly and I'm the director of the Institute. So welcome. These are monthly rounds and they'll be posted on YouTube for anyone who may have a colleague who have wanted to join but has been unable to. So we'll send that link out for you to share. We are actually thrilled to have Dr. Tim Hanna today presenting on his work exploring cancer care delays and the impact. And his work was published recently in BMJ, and I'll pop that up in the link here. It was in November, so you can take a look at the publication there. For those of you who don't know Dr. Hanna, he's associate professor and clinician scientist in the Department of Oncology and Queen's Cancer Research Institute, and also a radiation oncologist. His broad program of research looks at cancer healthcare services research, and specifically looking at access to and quality of cancer care. And in addition to his impressive research program, I'm happy to say I saw live that he's a new father to a brand new cute Labradoodle puppy. And so I'm sure he's keeping busy doing that along with all his research. So Tim, I hand the floor over to you.
Well, thanks so much, Catherine. Thanks for inviting me, and it's a real privilege and pleasure to have the chance to chat for these rounds. And yes, we're keeping very busy with the new addition to the family, and also teaching our 3-year-old identical twin boys as best we can how to gently treat a puppy. Can everyone hear me okay? It's good? Okay. I'm going to try to share my screen. So let me do that. Oh, spoiler alert. Okay.
Looks great, Tim.
Okay, great. All right. So as I go along, feel free if there are any questions to just shout out. Let me know. I may not see the little computerized hands go up, so if I miss it, just feel free to join in the chat. So I'll just get started.
I can hear you.
Nope, not at all.
Tim's droning voice.
I was going to say I recognize the voice.
All right. Sorry, so this talk is called Waiting for Cancer Treatment. And I'll give you a bit of background to the research that we did and chat about results, impact, and future directions. So it's hard to believe. It was about a year ago that pandemic hit us in Ontario. And around that time, my department head in oncology sent me a piece from Lancet Oncology with, it was maybe just a bit more than a dozen cancer patients in this COVID study, and talking about some of the severe impacts of COVID on this very small sample. And he asked for some comments on that, and really got me and a number of people thinking about COVID-19 and cancer patients and what needed to happen. One of the things that study did was say that we needed to basically defer any cancer treatments we possibly could, because in that setting in Wuhan, I think they were just so hard hit that they needed to make some hard decisions. But from the outside, it seemed kind of strange. Why would you ever need to do that? But as we headed into the pandemic, it all became a bit more real. So we wrote this piece over a matter of 2 weeks, and it was published in Nature Reviews Clinical Oncology, and just looked at prioritizing of cancer treatments during the pandemic, realizing that when resources became stretched and hard decisions had to be made, that it needed to be made in as just and fair and equitable way as possible. And so this opened up some of the conversation on this topic around the world, and really influenced some of the provincial policy on prioritization. And there were a number of principles that came in here, but things such as the magnitude of benefit, of the treatment and the impact of delaying treatment were factored into this conceptual model of prioritization. So at the very top, you would have treatment indications like imminent risk of early mortality if you don't quickly treat, for example, an acute leukemia, or very high on the list if you don't treat even with palliative treatment for malignant spinal cord compression, then someone could lose their ability to walk permanently. So that's a really important morbidity, despite the fact that there's no survival benefit to that treatment. And down at the bottom of the list are things where we delay them, and there's really no impact on the expected outcomes. So when I was working on this and Chris Booth were working on this, there were eight children at home between the two of us. We were doing our social distancing, isolation thing, and my boys are here losing their marbles as they're playing their games, and I think we felt we were a bit losing our marbles too a little bit as we were trying to get this all done very quickly. One of the paragraphs in this that we wrote about was just summarizing the world literature on the impact of treatment delay on mortality for cancer patients. And you can see by how short this paragraph is that there really wasn't a lot to say. And so one of the things that we brought up was the need for what's called the precautionary principle. And that basically states that in a setting where harm is plausible, but not scientifically plausible, but not absolutely certain, then care needs to be taken to minimize or avoid that potential harm. And really that was needed just because there were so many cancer treatment indications where it was very plausible that treatment delay could have an impact on outcomes, including survival. But the data there, at least valid high quality data, just wasn't there. So that was something certainly in my mind as we finished that study off, and eventually we circled back to it. So there's quite a long history of treatment delay research at Queen's. Bill Mackillop, Will King, Chris Booth, and others have put out a lot of really important research and influential research that took the world literature on this topic for a number of treatment indications and provided estimates of the impact of treatment delay on mortality per 4-week delay, so that you could quantify very specifically what that impact on the patients and the populations might be. So for example, here's a study looking at radiotherapy treatment indications and clinical outcomes. And this is back in 2008. And another one on adjuvant chemotherapy and survival in colorectal cancer. I see Jim is on the line, and Jim is the first author of this. So in March, as lockdown measures came into play the last year, we began to see deferrals of elective surgeries, including cancer surgeries. And a number of us started to become concerned that some of the prioritization was taking some of the priority items that are very high on the cancer treatment priority list and not dealing with them in the priority fashion that would be optimal. When we think about measuring the impact on cancer patients using ICES data, real world health administrative data, that is certainly super interesting and very doable with rigorous methods. But the problem with that is that to measure differences in cancer outcomes, you need to have years of follow-up. so that by the time we complete that ICS study, it's going to be too late to informing what we do during this pandemic. So certainly, the thought came to my mind about maybe we could do a model and use some of the available literature on these the limited treatment indications that had information on cancer treatment delay and mortality. So optimistically, I thought we could do a short letter to the editor, make it a 2-week project. We published that other Nature study I showed you. The whole process from proposal to publication was about 2.5 weeks, I think. But here I was way optimistic. Anyway, to have a good model, you need to have good underlying data. And as we started to head into trying to address the evidence need that we saw that there were a number of other rapidly published COVID models on cancer patients, but they use poorly justified estimates of treatment delay on mortality. So here's a very nice model. It's publicly available on the internet, produced by researchers at the University of Michigan, and they did a good job of collecting various studies to inform their model. But they ask the user of the model for specific indications to basically guess and put in what they think is an appropriate hazard ratio for the impact of treatment delay on cancer mortality. So we realized fairly quickly that more important than building a quick little model was the need to fundamentally better answer the question of the impact of treatment delay on cancer mortality. And so a team quickly grew, starting with Queen's researchers, including myself, Will King, Chris Booth, and then a number of trainees in public health sciences, radiation oncology residents, as well as very skilled and amazing partners at King's College London in the UK, particularly Richard Sullivan and Ajay Agarwal. And so we eventually published this. It was not the 2-week quick thing that I initially thought this might be. It ended up being 6 months. But after we had dealt with all of the requests and requirements that BMJ put our way, as well as all of the reviewers, really, I think this project could have easily taken a year or two. So I think a testament to the many people that worked very hard to make this happen and to make the information available in as timely a fashion as possible. So I'll go through what we did and how we did it. So the objective of this study was to quantify the association of cancer treatment delay and mortality for each 4-week increase in delay to inform cancer treatment pathways. And our design was a systematic review and meta-analysis. So this was not producing any new primary literature, but surveying the world literature on this topic. And sources were from the past 20 years. We thought going back further could involve treatment quality or types of treatment or staging that was no longer representative of how things were done. And just a brief note on systematic review of the topic of treatment delay. It's actually really hard to find these studies because they don't all naturally use the word treatment delay in the title. There are various keywords that include things like time, and as soon as you have a word like time, you get all kinds of hits that are completely unrelated to the topic of treatment delay. So anyway, there was a lot of studies that had to be sorted through to get to the ones that we wanted to identify. We looked at curative treatments. We did not look at palliative treatments. and covered the three pillars of cancer treatment: surgery, systemic therapy, and radiotherapy. And the cancers we looked at, we wanted them to be representative and cover cancers that were relevant around the world, not just in high-income countries. So this included bladder cancer, breast, colon, rectum, lung cancer, cervix cancer, and head and neck cancer. And these together represent almost half of all incident cancers in the world. Our outcome was the hazard ratio for overall survival for each 4-week delay. And we used a log linear assumption, which was, we thought, reasonable given some of the observations from prior delay studies. This was fairly novel in that we were able to take hazard ratios, delay estimates that were expressed in all sorts of different ways, whether they were continuous variables, dichotomous, or for multiple categories. We were able to bring all that information together, and that was important because of the non-standardized way that this topic is studied around the world. So there are unfortunately no high validity randomized trials that address this question, and really, I think fundamentally it's thought very reasonably to be unethical to do a randomized trial where you would delay some patients just to see whether that was detrimental to them or not. So it's historically that sort of study has never been done. I mean, you could argue for the reverse, where standard of care is the average delay in your system, and you make an intervention maybe to shorten that time for a select group of patients. But I've certainly not personally seen that actually come through in the literature. So as these were all observational studies that we dealt with, validity was a major concern. We thus wanted to only consider high validity studies, and in short, that had to include relevant prognostic factors and appropriately adjust for them. So at minimum, that included age, stage, comorbidity, and treatment information. You need to know exactly what treatment that patients in that study received. We also considered whether some of the indications adjusted for or considered the wait time paradox. So that this is the sicker, quicker paradox or issue, in that you might see that for people with more advanced disease, they're treated very quickly because they have acute symptoms that can't wait. So for example, with colon cancer, if you have an acute bowel obstruction, that may be associated with a more advanced and bulky large cancer with a poor outcome, but you have to operate on it quickly, as you're not going to make someone with bowel obstruction wait for months for surgery. They could die or end up with a very poor outcomes as a result. These are our results, our flow diagram. We started with almost 3,000 abstracts, and then identified 275 where we thought we needed to look at the manuscript to make some decisions. Among those 275 studies, the most important reason for exclusion was validity. 100 of those were excluded because they were not considered of high validity based on the criteria that I mentioned before. So that's an important lesson for sure, and maybe speaks to the need to better lay out guidance for how these sorts of studies should be done in the future. Ultimately, we ended up with 34 studies that we used to evaluate the impact of treatment delay on mortality of cancer patients. So we had 17 treatment indications that we a priori were considered. Well, I'll say there's 23 that were a priori considered, but only 17 had high validity data and 6 did not. There were 34 high validity studies for those 17 treatment indications, involving almost 1.3 million patients with a fairly broad range of sample sizes. Most of these were population-based studies, and actually most of them were from the United States. The US has a lot of very large population databases, and so there's a lot of studies from the US that address this question. Weight data was categorized or presented rather in a wide range of ways, as we expected, and the waiting times were generally between 3 to 4 weeks and 16 weeks, which really reflects a typical range of waiting times for various forms of cancer treatment. We were asked by the reviewers in BMJ about some of the other variables that were adjusted for in these analyses. And just to summarize, most studies, 91%, adjusted for socioeconomic variables, and this included a range of things, including socioeconomic status, income, education, race is considered in many of the US studies. 82% considered insurance status, especially as many of these studies were from the United States. 65% year of treatment, which could be important as treatment outcomes and efficacy might change over time, especially over the 20 years that we considered. And 88% included institutional or geographic factors. So I'll show you our forest plots, our results broken down by the treatment modality. For surgery, the hazard ratios were remarkably consistent. So this was certainly not a hypothesis we had before we started, and we would not have been able to predict this, but the hazard ratios per 4-week delay were all 1.06, except for breast cancer, where it was virtually the same. It was 1.08. So very consistent findings, and it was nice, not expected, but nice that this was so consistent and powerful, because I think this study attracted attention because of, especially because of delays in surgery that had been happening around the world during various lockdowns. For systemic therapy, the hazard ratios were more variable. So they range from 1.01 up to 1.28. And it's unclear exactly why that might be. My hypothesis is that when those surgical studies were done, they basically were taking all comers with those cancers. So amongst those groups, you'll have many patients with lower risk, more indolent disease, as well as those with higher risk advanced disease that, for example, may have spread to the lymph nodes already. And when we're talking about adjuvant or neoadjuvant systemic therapy, we're talking about treatment indications for specific high-risk groups, and also the systemic therapy used for each of these indications, or the types of systemic therapy, could have different effectiveness for each of these indications. So perhaps that's why there's more variability here. Of course, there are other factors such as unmeasured confounding or just random chance that might lead to some of this. I'm a radiation oncologist, so I was especially interested in the radiotherapy data, and sadly, there was the least high validity data that we found when it came to the modalities for radiotherapy. So there was only one study for each of these indications, and there were many other indications, such as radical radiotherapy for lung cancer, that we found no high validity studies for. So that's certainly an evidence need. This is an infographic that summarizes what we found in the study. And I'll draw your attention to the bottom, just to help give an example for what these these hazard ratios mean and how they might be used. With this example, if you considered 1,000 women who required breast cancer surgery, we stated that the hazard ratio per 4-week delay was 1.08 for that group. So if there was no delay, we would expect about 120 of these 1,000 women to die after the diagnosis of breast cancer. If there was an increase in mortality of 1.08, then you're basically multiplying the 120 by 1.08. And what that means is that there are about 10 additional deaths due to delay that are estimated based on our results with a 4-week delay. And then with 8 weeks, that would increase to 20, and then to 12 weeks to 31. And so these estimates will vary depending on both what the hazard ratio is, but also what the baseline mortality is. So for example, for colon cancer, the baseline mortality would be expected to be higher, and so that would impact on the estimates from that. So what we found was that even a 4-week treatment delay was associated with mortality across all 3 modalities using the highest validity data that is available in the world literature. And that impact of delay increases with longer delay. And I'll really emphasize that the purpose of the discussion and the project was really on reducing system level delay. So certainly we're not trying to say that people should be rushed without appropriate staging and preoperative preparation into surgery or other forms of treatment. That's not what the conversation is about, and we emphasize that in the paper's discussion. As for any study, there are important limitations and caveats. We can't extrapolate beyond the available data, and as I mentioned, largely the data covers weights between 4 and 16 weeks. And in some cases, that might not be enough to cover delays that we are seeing. For example, in lower resource settings, delays can be longer, even pandemic aside. And in some regions, I imagine that the pandemic may have caused delays longer than this range. The other thing is that we can't just assume that the exact numbers we found relate to other indications we haven't considered. But certainly, where there is absence of evidence, it's not evidence of absence. And so the precautionary principle absolutely comes into play. There's always a risk of residual confounding. Studies that are looking at differences in survival at the population level are challenging to complete, and certainly there are variables that we would like to have that we don't always have in our models, in our data sets. And we assumed log linear assumption, which is I think a fairly reasonable assumption, but even if it's not correct, when we're talking about delays between 4 and 16 weeks, this is probably a reasonable assumption to make. And the other thing just to emphasize is that because what we're estimating is based on a continuous relationship, it's not to say that say a 3-week delay is safe based on our findings. Our results don't consider the impact on other cancers, as I've already said, on local control, functional outcomes, complications that could result from more extensive treatments because of unnecessary waiting, quality of life for people and their families, economic burden of higher care costs and productivity loss, and diagnostic delay. And this right now is actually a big issue due to what's been happening with some of the challenges in accessing diagnostic services for people that will ultimately be diagnosed with cancer. So, you know, our findings do suggest that policies aimed at reducing system-level delay could improve survival and possibly save lives for many people diagnosed with cancer. And there's certainly many ways, maybe endless ways, that that we could consider to reduce waiting times. And these are just a few examples. There are certainly others, but for radiotherapy, automated contouring with artificial intelligence might provide us gains. Satellite centers, centralized waiting lists. We've certainly seen some centralization of services or sharing of services across regions for critically ill patients in Ontario during the pandemic. Super specialized services or innovations in surgery. So surgical procedures that would be possible to be done with limited or no admission to hospital. So the other thing, you know, thinking beyond the pandemic, because this was not in the way that we published it, it was not really a COVID study. It was just inspired by COVID. Waiting times is a perennial issue, and certainly I think, you know, there'll be one that we're stuck with for years to come. And if we thought about just the 5 cancers that I've listed here, and only thought about shortening surgical wait times in Canada over a 1-year period, in that red rectangle there, there are possibly hundreds of lives that could be saved by shortening waiting times, even by 4 weeks. And this is, of course, a very simplistic estimate, but I think it just emphasizes that you know, possibly some very in conceptually simple things that we could do could have maybe as much or more impact than some of the novel new treatments that are coming out in oncology that are sometimes extremely expensive and may not even increase survival. So of course, you know, if you're thinking about even an intervention like reducing waiting times, which if used properly really would have no side effects, there's of course issues of cost effectiveness. And there's this study that just provides an example of how you might consider the cost effectiveness of reducing waiting times, and this is for head and neck cancer patients. And in this case, it was found that for the interventions they used, which for one was doing the throat biopsy under local anesthetic, not in the operating room, could shave off weeks of patients' waiting time, and it was very cost effective. So of course, it all depends on how your system's already set up as to whether the interventions being proposed are going to be helpful or not. So certainly, as I've already spoken to a bit, there's a need for more research, and that's been pointed out by others. We need to create more evidence for the treatment indications that we looked at and consider other treatment indications beyond those that we considered. And certainly our results do have some relevance to COVID-19 now, but it's not just treatment delay, but also, as I was saying, diagnostic delay. And I think both of them together are really important to consider right now. And I'll just skip through some of this, but this slide was just to say that the dialogue about this topic has really been global, and the coloration on this map just indicates countries where people have been tweeting about this. And you'll notice it even covers countries in Africa, South America, and many other parts of the world. I'll just briefly mention that we never did end up doing that 2-week COVID model that we talked about, which is maybe a good thing, because a much more robust international consortium has been struck by the Union for International Cancer Control, the WHO International Agency for Research on Cancer, Canadian Partnership Against Cancer, Australian groups, and this is looking at modeling all sorts of impacts of COVID on cancer patients, and certainly what we produce with our delay estimates provides some valid and robust as possible data that this amazing group can use. But I just wanted to return briefly to the topic of diagnostic delay. And this is another area of expertise at Queen's. Patty Groom, for example, is really, I think, a world leader in the study of this. This has been a really important topic because some of the pathways for diagnosis have been harder to access, or for a time have been slowed down, or had been even shut down early in the pandemic. I thought I would put in some of our research on the topic from Ontario. So I treat skin cancer, so our community has been very interested in this. And the orange bars represent the number of COVID cases in Ontario, spanning from the first week in January of 2020 to the 38th week. The dark blue line represents the number of skin biopsies performed in Ontario for a given week in 2019. So this is the baseline, if you will, and the light blue line represents biopsies performed each week in Ontario, basically over the pandemic. And you can see in the early part of the lockdown, the 10th to 15th week, around March, April, dramatic drops in the number of biopsies performed. And these biopsies are crucial to diagnose skin cancer, including melanoma, which can be lethal. And there's a rapid drop and then a gradual increase in biopsy rates, but they even out half a year beyond the time of the initial lockdown effects. The light blue line never actually rises above the solid blue line. And that's quite concerning because we know year to year there's increased incidence of cancer. So even if nothing happened, there was no pandemic, we would want to see at least equal or slightly higher diagnostic procedures being performed. But even with this big drop initially in the lockdown, we're not seeing kind of recovery levels happening. So there's still in the tens of thousands range of skin biopsies that are outstanding. And this is not just the skin cancer phenomenon. Other studies in the UK, in France, and in the United States have seen similar patterns, suggesting that diagnostic delay is an issue we're going to be contending with probably for the next few years in oncology. Just some data from the waiting time information system in Ontario for breast surgery. If you look at the first 2 quarters in 2020, the average waiting time from decision to completed surgery for breast cancer rose, by from maybe 26 to 35 days. So not a dramatic change, but certainly not nice to see. But the waiting times have been controlled once the patient gets into the system quite well. I think this relates to prioritization of cancer patients in Ontario in a positive way. But when you look at the number of patients who are actually undergoing surgery in the first 3 quarters of 2020, there's quite a dramatic drop in the number of people having surgery. And I think that probably speaks to largely a diagnostic delay issue. So this is around 2,200 less cases than in 2019, which is certainly a concern. And this is only for breast cancer. You could put up similar figures for other cancers that are measured. So I think ultimately I'll just end to say, on World Cancer Day this year, on February the 4th, a message was put out by members of the Canadian Cancer Society, just speaking to the topic that, yes, we need to clear the backlog, but we also need to build a better healthcare system, one that's resilient and able to face whatever crisis we face next. It probably won't be another once in 100-year pandemic. We won't be able to predict exactly what the next major crisis is, but we need to have a system that's able to be resilient and has new opportunities and abilities to deal with the unexpected. And I think that speaks a lot to having effective and agile and almost real-time information systems, as well as innovations in how we deliver care, as well as the content of that care. So just a simple example for oncology, having oral drugs that could allow more flexibility on the number of visits to hospital compared to IV drugs that would be typically administered in an outpatient clinic, allowed more flexibility in delivering oncologic care. And there are other examples too from radiation oncology. So in conclusion, we found that there's an association between per 4-week delay and mortality across all major types of cancer treatment and 7 major cancer types, and that mortality increases as delay increases. More research is certainly required, and certainly I think we have a call for clearing the backlog, but also building back better.
Thanks very much, Tim. You covered a lot of ground and, I wrote a number of notes and a lot to think about, and, it really sheds light on the broad impact of COVID and the impact really for years to come, and how we'll be studying this and how it's going to take some time. And it's really quite impressive, the uptake you've had globally. I'm just going to have a question just in light of the fact that, this was looking retrospectively, looking at a systematic review and meta-analysis. Are you planning to do work currently on data coming out, or are you conducting work?
Yeah, absolutely. So I just can't stand to see the bad data, especially for radiotherapy. I mean, the lack of data. So actually we have a couple projects that I'm just digging into, specifically looking at lung cancer, because that's one that it's a very high incidence, high mortality cancer worldwide and in Ontario, and the data just is not there, but also there's a lot of concern that there really is an impact of delay on outcomes. And because actually our care is more advanced and involves so many more people, it's multidisciplinary, it involves all kinds of complex imaging, it's all good, but it's just meant that it takes longer to get everything done.
Well, and I just want to say, you said that it was a 2-week study, which was highly optimistic. It's impressive, but even 6 months is shockingly quick, really, to think that you were able to do this level, and it's really quite amazing and impressive. I'm just going to open it up. I'm sure there's other people who have questions, and I'll if you want to put in the chat, I can help moderate.
Can you see that my hand's up? Can you hear me?
I can't, but jump right in.
Yeah, it's Dr. Joy Hatley here. I apologize because I'm actually in the OR taking this in, but I think this is critically important. I'm the District 7 Ontario Medical Association chair. And my question really is, how could we have done this better? Like, why did this shutdown happen in the healthcare system? It seems like in a pandemic, the most important industry to stay open would be the healthcare system. And yet there's this general perception in the community that family doctors are closed and clinics are closed, and it just seems like a paradox to me that in a healthcare crisis, the healthcare system wouldn't have remained maximally accessible to patients.
Yeah, it's a really important question, and I don't think I can completely answer it myself. I hope we have some good conversation on it now and in the months to come. But I mean, I guess initially when this pandemic hit, we saw what was happening in Italy. It raised a lot of concern that the healthcare system was going to be completely overwhelmed with this massive surge that happened all at once of COVID. And so there was quite a strong reaction that I think, in retrospect now, I think it's more obvious that we could have taken a regional approach for one, which would have allowed us to maintain services for non-COVID patients much better. I think the issue with accessing primary care is, it's a really important one to raise. Like, from some of the patients I talk to, I feel like, yeah, they just assume that their family doctor is not accessible, and there's almost, for some, just this, they just kind of accept it and pretend that they just can't get anything. And I've seen some of my colleagues in oncology doing primary care things that they wouldn't have done before, just because patients feel that their GPs are not accessible to them. And certainly that's a big issue for diagnostic delay because of the wide range of ways that people get into, for example, the cancer system. Many of those are through primary care. For just one example, cervical screening.
Those are great. Sorry, I'll let you have a question.
Great presentation, Tim. I just want to speak to the primary care component. It is true that initially there was a big drop in the amount of care provided, but very quickly virtual care compensated, and there was a fair bit of virtual care in the primary care sector. I'm just wondering, can you comment on a couple things? Did we also see the equivalent uptake in virtual care in the oncology sector? And are you aware of any studies that plan to look at that particular piece within this area? Because I know there's quite a bit of work being done on virtual care and the impact it's had during the pandemic. I'm just wondering, are there any similar approaches being done in your area?
Yeah. Thanks, Elliot. Yeah, that's a great question. Yeah, certainly there was a lot of virtual care that happened in oncology, and I think maybe it was a good experience for oncology because of for many forms of cancer, we see people in person follow-up for years, and maybe this has given us more of a sense for what we think we can safely do virtually. So I think it's an important question, and yes, I know that there's a study going on from Queen's investigators looking at the question of virtual care. It's survey based, so it's not an ICS study, looking at the virtual care codes or that sort of thing. But it's a really good question. I'm not aware of anyone doing an ICS study on that, but it would be interesting to see. I've certainly, in my practice, it's been a learning experience because I treat skin cancer, and you can do some of that virtually, but when it comes to making the important decisions, you need to see people in person. So it's been interesting to figure out what I can and can't do virtually.
I think the issue of you had a number of different policy recommendations, Tim, and I'm just circling back to what you said about people not necessarily being aware that their primary care physicians were open, and just from a policy, or I guess more of a communications perspective, I can see how crucial it is to get the word out for people to understand that. There's a question in the chat. It's a broader question for you, Tim. I'm just going to bring it up and ask you. So this is more of a prevention question. In the long term, would avoiding carcinogens in food, for instance, reduce the incidence of cancer? So more of sort of thinking incidence and just talking about cancer and incidence over the years.
Yeah, it's a really important topic. And it speaks to the fact that cancer control is much broader than cancer care. So, we do a lot of stuff in cancer centers to deal with cancer once it happens. But number one, we want early detection, which simplifies treatment. But to avoid cancer where we can, is really important. And I mean, that reduces morbidity probably the most. You know, to the general question of carcinogens in foods, I mean, there's certainly epidemiologic studies that help us through IARC, for example, in identifying which of those foods are of the greatest concern and risk. And you know, certainly it's something that needs to be incorporated into, you know, public health at large.
Opening it up to anyone else who might have a question for Dr. Hanna. Just had one further comment, if there wasn't another from the chat or the audience. Tim, a lot of these studies, and I'm just intrigued by your thoughts, are from the US.
Yeah.
And so just some thoughts from, and you sort of made a comment about low resource settings. And, you know, a lot of your policy recommendations in my mind were from these more high resource centers. What are your thoughts from lower resource countries, and, you know, your thoughts just in terms of wait times and what they might be able to do?
Yeah. So, I mean, we didn't include this in our report, but there are differences in the impact of delay in mortality depending on stage. And stage is going to be different for many countries, especially, you know, where there aren't a lot of resources and people need to wait longer before they get to their treatment. I mean, our results in general support the principle that wherever we can effectively look at it, delay in most cases seems to matter for cancer patients. So that's useful to limited resource settings. But it's, I think it emphasizes that studies that are relevant to low resource settings need to happen in those settings, and that when we interpret our results, stage distributions from high-income countries need to be taken into account.
Thank you for that. And I guess it links to the importance of data and just the access to data in the US, right? So their story gets told.
Yeah.
Over.
And you know, apart from the US, probably the most studies in the world came from Queens.
Go Queens. Well, that's the power of having sort of focused attention in a program of research. It's impressive. On that note, it's 5:02, and I know people probably are transitioning to the next Zoom meeting, or hopefully maybe taking a lunch break. I just want to say on behalf of HSPRI, Tim, thank you for presenting and for this really impressive body of work. Bye, everybody. Thanks very much.
Have a good afternoon, everyone.